We're going to go ahead and get started. We have a very exciting morning ahead of us. So we have a special grand rounds today planned to discuss Ebola. We have three wonderful faculty members and a faculty member who is abroad who has very kindly written a letter on his behalf to talk about his experience in West Africa. So I'd like to introduce Dr. Jeff Duchin, who's the Chief of Communicable Disease Epidemiology and Immunization section at the Seattle King County Public Health Department and a professor of medicine in the Division of Allergy and Infectious Disease. And he's been very involved working on the public health perspective and has a lot of experience working with the CDC, both in the past and currently. Dr. Tim Dellit, who's an associate professor of medicine in the Division of Allergy and Infectious Disease, associate dean of clinical affairs at the University of Washington, and associate medical director at Harborview Medical Center. And he has been very active in the University of Washington medicine in our role as the regional response to the Ebola crisis. And Dr. John Lynch, who is an associate professor in the Division of Allergy and Infectious Disease, medical director of Harborview's Infection Control, medical director of Harborview's Employee Health, medical director of Harborview's Antimicrobial Stewardship program. And he's been very involved in the news, like the other two, with local preparations over at Harborview. And the final one is Dr. Shevin Jacob, who is an acting assistant professor in the Division of Allergy and Infectious Disease, who has spent the last 7 months in West Africa, both in Liberia and Sierra Leone, and unfortunately couldn't join us today in person or by teleconference, but has written a letter describing some of his experiences over the past 7 months. So I'm going to start by reading his letter, and then the three panelists will come up, each will speak, and then we'll open it up for discussion. So Dr. Jacob wrote, "Dear friends and colleagues, I am writing this letter from Monrovia Airport in Liberia, where I've been working as a World Health Organization consultant for the past 7 weeks, training healthcare workers to be able to work safely in the numerous Ebola treatment units that are being built throughout Liberia. I sit here waiting for a UN flight to Freetown, where I've been asked by the World Health Organization to help manage an Ebola treatment unit, which has been opened prematurely in the midst of an upswing in cases in Sierra Leone's capital city. This deployment will be my 4th deployment as a World Health Organization consultant since April. My first deployment was to Guinea-Conakry in early April. When the outbreak in Guinea had spread from the southern region to the capital Conakry, we dreaded what might be the implications of Ebola for the first time, spreading in a major city in Africa, where crowding, poor hygiene, and an already dysfunctional health system existed. My place of work was at a former cholera unit at the Duchin National Referral Hospital, which had been transformed by Doctors Without Borders into a full-fledged Ebola treatment unit. Each day, we would work side by side with Guinean Doctors Without Borders and World Health Organization colleagues to care for patients in what seemed like an impossibly challenging setting. Start with the humid climate with temperatures exceeding 90 degrees Fahrenheit. Add to that layers of personal protective equipment, which resulted in volumes of fluid loss through sweat, difficult vision through fogged face shields, and muffled speech through N95 masks. Add to that the fact that the the Doctors Without Borders health workers had even more restricting personal protective equipment, which limited their time in the unit to 1 hour or less to mitigate the real risk of heat shock, leaving the World Health Organization doctors in lighter personal protective equipment to stay longer to care for patients. There were only 2 of us. Add to that the reality that the majority of patients speak French, and my French is mediocre at best. Somehow, we managed to work together to provide some semblance of care. When I first arrived, there were 14 patients on the ward. In time, the team overcame the challenges and started to work as a well-oiled machine. One day, a cluster of 10 family members who had attended the funeral of a relative suspected to have Ebola descended upon the unit and our efficient system fell apart. All of the challenges I just mentioned became magnified. For reference sake, my first work with viral hemorrhagic fevers was in 2012 during the Marburg outbreak in southwest Uganda, where the treatment unit had a capacity of 6 patients and it was rarely full. With some creative approaches to staggering shifts to take into consideration the limitations imposed by different personal protective equipment worn by Doctors Without Borders and World Health Organization staff, we ultimately managed to gain control of the situation. While several of the patients ended up dying, we also managed to provide aggressive supportive care, which led to being able to discharge some of the survivors from this outbreak. When I left Conakry 4 weeks later, there was 1 patient remaining in the Ebola treatment unit. As we have seen in many other outbreaks in Uganda, I suspected that the outbreak would trickle, along with another month, and then the region would be Ebola-free by the end of June. Little did any of us know what Ebola had in store for us. In August, I returned to West Africa, this time to Sierra Leone to work in an Ebola treatment unit in Kenema General Hospital in the west of Sierra Leone. As you know, the outbreak, in fact, never went away as we had all hoped. Instead, it found pockets of vulnerability throughout Guinea and moved stealthily in the fluids of exposed patients across the porous borders of neighboring Sierra Leone and Liberia. Because the communities who live in these border communities coexist with a high level of commerce and intermarriage, people who got sick in one country could easily find refuge at a relative's house in another country to evade being approached by the aliens in yellow or white suits, quote unquote. This evasion has resulted in a global emergency where, as I write, nearly every county in these three countries has been affected by Ebola. Where I worked in Kenema, the border to Guinea was less than 100 kilometers. At the time, the global response to the outbreak was still inadequate. We had relinquished our small pool of World Health Organization clinicians earlier in Guinea, yet the numbers of patients were exponentially greater than anything we could have imagined a few months earlier. Moreover, the number of health workers who have been exposed, infected, and died from Ebola were continuing to increase. The week I had arrived, the country had mourned the loss of one of their heroes, Dr. Humar Khan, who had just succumbed to the disease a week before. In fact, 12 other healthcare workers from that same hospital had also died. Together with another infectious diseases physician from Tulane University, we took over the reins from the outgoing team of World Health Organization physicians. This time, the support from Doctors Without Borders' army of logisticians, water and sanitation and hygienist experts was not present. We were a motley team of 8, 2 physicians, 2 logisticians, 3 epidemiologists, and a coordinator. The Sierra Leonean nurses were shell-shocked and resisted re-entering the place where they believed their departed colleagues had transmitted the virus. Yet the number of patients continued to rise to a point when we were caring for a ward of 90 to 100 patients. With the help of a British nurse by the name of Will Pooley and 3 courageous Sierra Leonean nurses, we cobbled together some order in all of the chaos. Days were grueling, up to 5 hours at a time in personal protective equipment. Extremely sick patients with diarrhea and vomiting and occasional blood in a messy ward. Pregnant women miscarrying. Unaccompanied orphan children. Blackouts. Mice. Spiders. Seriously, spiders. We fought for those patients, though. Our team was small, but we saw time and time again that aggressive fluid resuscitation started just before initial period of gastrointestinal phase of the illness began could bring someone back from the brink of death. Those wins were enough to keep us going, to be indelibly imprinted in my head. There was also incredible hope and humanity in that ward. At any given time, there were about 15% convalescent patients, people who had survived the worst of the virus and were recovering as they waited for the Ebola viral loads to become undetectable. On occasion, these patients would be angels in the dark who could help us to monitor the sickest patients and watch over the orphan children to ensure they were eating their meals or drinking their oral rehydration salt solution. I felt they were the guardians of the ward, not only looking after the patients who needed the most help, but somehow elevating our spirits after long days which were both physically and emotionally draining. As we walked out each evening, the convalescent patients would be gathering on the veranda near the entrance to the ward. People were telling jokes, laughing, eating, and even singing. On these nights, I truly felt that the Ebola did not have to be a fatal diagnosis. And though challenging, we were playing some part in the increasing, growing pool of Ebola survivors. This time around, my role in Sierra Leone will be completely different. As in my last deployment in Liberia, I will focus my efforts on building the capacity of health workers to safely care for patients in an Ebola treatment unit. Throughout the training course, we emphasize and re-emphasize the motto of the training, quote, to protect ourselves so we can save lives. I hope that by imparting the lessons I have learned over the past 7 months, this battalion of health workers will be able to give the necessary, aggressive, supportive care in the safest way possible. Indeed, returning to Sierra Leone this time will be bittersweet. After I left Kenema at the end of August, 2 nurses with whom we worked succumbed to Ebola. I had promised them I'd return so that we could dance together someday in celebration of the defeat of Ebola. I still look forward to the day when we can celebrate something here in the West African countries, which have had their health system decimated by this outbreak. In the meantime, I am here to focus on the present so that the loss of the lives of our colleagues and patients has not been in vain. Thank you for giving me a forum to share my experience in an unconventional manner of grand rounds. Thank you also to my friends and colleagues in the Division of Allergy and Infectious Diseases who have been incredibly supportive throughout the entire outbreak. I know that there are several of you in the audience who are considering joining the front lines to respond to the Ebola outbreak in West Africa. Please feel free to ask for my contact information from the Division of Allergy and Infectious Diseases, and when I am in a place with better bandwidth, I will be happy to talk to you. So I would now like to introduce our first speaker, Dr. Jeff Duchin.
Well, good morning. That was a very moving letter. Thanks for reading that, and it really sets up my first point. Although we're going to be speaking a lot about Ebola in the U.S. today, the problem, really, the global public health emergency is in Africa, and that's where we really need to focus all of our energy and efforts getting that outbreak under control. I have a very limited time, as we all do, so I'm only going to hit on a few points, and there's going to be a lot that you're probably interested in, so hopefully we can get to some of the things that I can't mention in the question and answer. So I'm going to, I think, maybe make 5 main points. One is that the public health emergency is in West Africa. This is the map of Ebola-affected countries. Is there a pointer available by any chance? No pointer? Oh, use the mouse, okay. Oh, there we go. Okay, so it's very important to understand where the outbreak is occurring. So Guinea, Sierra Leone, Liberia. There's some action in Mali. There may be additional cases there. We'll see what happens. But a little familiarity with geography is important. This is Equatorial Guinea. This is not where the outbreak is occurring. New Guinea is not where the outbreak is occurring. As a clinician, you need to know where the affected countries are. It is the single most important piece of information that you need in order to understand whether someone is at risk for Ebola disease. These are countries without widespread transmission, where there have been previous cases and where travelers are not currently considered to be at risk. And these are countries without current transmission where previous cases occurred, where travelers are not considered to be at risk unless they tell you they've been in contact with a known Ebola case. So this current outbreak is greater than all previous outbreaks combined. This graph shows since 1976, the previous largest outbreaks, and you can see that the number of cases in the current, it's bouncing around. The number of cases in the current outbreak, about 14,000 with over 5,000 deaths, and this is probably a significant underestimate, dwarfs the numbers of cases that presented in previous outbreaks. And predictions are very grim. This is the worst case and best case scenarios from the CDC's publication, which is online at their website, which suggests that by January there may be over 1 million cases occurring, which is phenomenal to think about and would be a major catastrophe. In recognition of this, not only the World Health Organization, but the UN Security Council declared in September that this outbreak was unprecedented. It constituted a threat to international peace and security, and called on all member states to respond urgently to the crisis and refrain from isolating the affected countries. Okay, so you've probably seen a lot of this. My second point is Ebola is not easy to catch. So this is a number of diseases with which you're familiar, ranked by their reproductive number. The reproductive number is basically the number of secondary cases that a single case would produce if it was introduced into a susceptible population. And you can see that measles is highly contagious. A single case will result in 12 to 18 secondary cases, similarly pertussis, chickenpox, and so on. These diseases, even in the mid-range on this graph, mumps, rubella, smallpox, are considered to be highly infectious diseases. You go down to the bottom of the list, you see Ebola at 1.5 to 2. So the number of secondary cases generated is not high compared to many of the diseases with which we are familiar and we treat routinely. However, the case fatality rate is. And this is what is generating a lot of the anxiety about the disease, both the unfamiliarity, but the high case fatality rates that have been seen in Africa. Now, here in the U.S., well, granted, we've had a small number of cases, all have survived. So we have a case fatality rate of 0 right now. This virus is present in high quantities in blood as people become ill, and it's present in a number of other body fluids. But it really begins at low levels, and when symptoms begin, which are very nonspecific and influenza-like, the virus sometimes is undetectable, and it rises to become very high as the course of the illness progresses. So how do people get exposed and infected? Usually direct contact with the blood or body fluids of an infected person. That could be through broken skin, through a breach in personal protective equipment, or through unprotected mucous membranes, family member, household member taking care of an ill patient. Could be a sharps or needle stick injury. in Africa, the direct contact with the corpse of an infected person is the major way that this disease is being transmitted in the community. And less likely, but theoretically, indirect contact with contaminated environments, such as linens or surfaces. This disease can be acquired through eating bushmeat in Africa, and there's a theoretical possibility that imported bushmeat could be infected, although that's never happened and is thought to be low likelihood because it's not a hardy virus and doesn't maintain viability for a long time outside the host. It's really important to understand that infected persons are not contagious until the onset of symptoms based on all the available data from this outbreak and past outbreaks. The infectiousness increases as the disease progresses, so that people early in the infection are unlikely to transmit it, and that's been evidenced here in the U.S. during the current outbreak when none of the contacts of Mr. Duchin, the first case that was treated at Texas Children's, including the ambulance drivers who transported him before it was recognized he had Ebola, and that same rig was used for 3 days before it was decontaminated. None of the people that were in contact with him, even in his household where he stayed while he was very ill for several days before he was hospitalized after he was sent home the first time, became ill. The 2 healthcare workers that cared for him early in his illness before he was known to have Ebola and didn't use what we would use today if we knew we were caring for an Ebola patient did become infected, but those were the only ones. Human-to-human transmission of Ebola virus through the inhalation route is a theoretical consideration, hasn't been demonstrated, is not thought to have occurred, and although it's been theoretically raised as a possibility because animals that have been exposed to aerosolized Ebola have been infected, it's not thought to be something that happens in nature. Okay, I'm not going to go over the Ebola cases in the U.S. I just want to mention that of the 177 contacts of the Dallas case that were monitored, none have become ill. And so far, none of the contacts of Dr. Spencer, the case that was hospitalized at Bellevue in New York, have become ill. So other than the 2 nurses, none of the contacts of any of the Ebola cases that have been in the U.S. have become ill. Nonetheless, 2/3 of Americans worry about a possible widespread epidemic of Ebola in the U.S. So my third point is that an outbreak of Ebola in the U.S. is very unlikely. This is a really succinct slide that shows why that's so. So these are the factors that increase the risk of Ebola outbreaks, and you can compare what the situation is in West Africa, where Shevin is working, and here in the U.S. So poor healthcare system infrastructure, lack of public health capacity, very ill patients cared for in the home with lots of opportunity for transmission, traditional burial practices by families, all are occurring in West Africa to a great extent, but not in the U.S. Mistrust of authority is great in Africa. There have been years of civil war, strife, and mistrust of governmental and other authorities. In the U.S., we have that to some degree, but nothing like what was present in Africa. And we have good access to information on how to reduce the risk here in the U.S., and that was very challenging to disseminate in Africa, again, because of both the mistrust and the lack of infrastructure with which to do that. And we have very good access to medical care early in the illness, whereas patients can be isolated before they become contagious, and that is not the case in Africa. Okay, so getting back to you all. My fourth point is that all healthcare providers should know how to screen and manage a potential Ebola case in their practice setting. Regardless of where you practice, you need to understand the fundamentals, and there are a lot of good tools that are available to you on the CDC website, and they all have this in common. You need to be able to identify, isolate, and inform. So basically, the number one priority is knowing the exposure history. Has someone been to a country where Ebola is occurring, where a widespread Ebola outbreak is occurring, or have they had contact with someone with known Ebola in the past 21 days? That's the first question. 99.9% of people are going to answer that negative. And then you continue with your usual triage and assessment. But if they say yes, if you have a traveler that's just returned from Liberia, or someone that's been a healthcare worker that's been caring for patients like Shevin, then the next question is, are they symptomatic? And if they are symptomatic, they are meeting the CDC case definition for a person under investigation. That's someone that really needs to be paid serious attention to and isolated immediately. Whether or not they're symptomatic, you need to contact your local public health jurisdiction. I assume most of you are here in King County in Seattle. That would be calling us at Public Health Seattle, King County. But if you're outside the county, regardless of whether the person is symptomatic, if they've had an Ebola exposure, we want to know about it and monitor. So there are guidelines both for ambulatory care and emergency department management, but the basic guidance is the patient needs to be isolated immediately, avoid any unnecessary direct contact with the patient. There are guidelines for the type of PPE that should be used while the patient is isolated, and the health department is informed to arrange transport to a facility that's prepared to do a definitive evaluation and management on a possible Ebola case. So both ER and ambulatory care guidance available on the CDC website. Okay, so this is my last point. Many of you remember, the early days of the Ebola outbreak. I think we blew it in terms of risk communication. There was a little bit, I think, too much optimism and reassurance about how readily we could control the outbreak. Now, clearly, this outbreak can be controlled very readily in the U.S. through isolation, identification of contacts, monitoring of contacts, and using personal protective equipment. However, the meticulous attention to the use of personal protective equipment has proved to be more challenging than was anticipated. And so it's really not the case that every hospital can take care of Ebola, as was initially declared. So it's very important to understand the principles of risk communication. So risk, which is basically here the public perception of risk, okay? What the public understands as risk is a combination of the true hazard, which is what we as scientists understand as risk, the low likelihood that someone in the public will get Ebola, so the true statistical mathematical risk of Ebola, plus the outrage factor, which is basically the fear factor, the lack of control, all the things that make people worry about Ebola. This is what drives the public perception of risk. And you're familiar with all the crazy things that happened in that context. Schools closing in Texas and Ohio. This won't stay still. An epidemic of fear and anxiety hit Americans amid the Ebola outbreak, and so on. So understanding the principles of risk communication, probably, and paying a little more attention to the outstanding influence of outrage earlier in the epidemic would have been useful. Clearly, the disproportionate, overly restrictive quarantine measures that were implemented by some states are a reflection of that, and the election that was happening. So my last slide really is meant to segue into what Tim and John are going to talk about. Locally, we have a regionalization strategy for healthcare system preparedness. We no longer believe that every hospital is capable or appropriate to care for a sick Ebola patient. So we're identifying certain hospitals regionally throughout the state that will be centers of excellence for Ebola. Most healthcare facilities should be able to do the risk assessment, evaluate and isolate a person under investigation, possibly hospitalize the low-risk case and rule out Ebola, and then find out what's really wrong with the person. But we're really focusing now on a small number of Ebola-ready healthcare facilities that will manage confirmed and critically ill Ebola cases. And this involves enhanced planning, which Tim and John are going to describe along a variety of different fronts. And this has been a collaborative effort here in King County between the regional hospitals and the Northwest Healthcare Response Network and Washington Department of Health and CDC, who will be helping us assess facilities as soon as they're done with the communities that have a higher risk for Ebola. So I'm going to stop here. I'll leave you to think about that for a sec while Tim comes up, and then you hear about John. If we have time, we could talk more about travel and quarantine and so on. So let me take this away. There you go, Dr. Dellit.
Great, so good morning. So I'm going to talk a little bit about our approach from a UW medicine system and really emphasize the collaboration with CDC, Washington State Department of Health, our local public health jurisdictions as we really think about this from a regional perspective. And then John will give some concrete examples of what we're doing specifically at Harborview. So first, I want to just kind of discuss again, how could a potential patient with Ebola come into our system or our region, if we think of it in that sense. And as Jeff alluded, all of our emergency departments and clinics have to be really aware of and screening for potential patients, looking for individuals with potential symptoms, which can be vague and flu-like, as well as that exposure history, particularly travel to one of those 3 West African countries within the last 3 weeks. We also here in Seattle are one of the 20 designated quarantine sites around the country, which is illustrated in that map. And so if a patient gets off a plane with a potential infectious disease, say, for instance, measles, and they're evaluated by the CDC quarantine team, based on a long-standing agreement, those individuals would come to Harborview should they require further hospitalization. Similarly, if someone gets off the plane and they have symptoms concerning for Ebola and a recent travel history to Liberia, they're going to come into Harborview for further evaluation, and that's been a long-standing collaboration with public health. We also now, because a number of our faculty, other providers in our community, including nursing staff, are actually over on the front lines assisting in this humanitarian crisis. Should they return to our communities, they are under active monitoring for the potential development of symptoms. And roughly right now, there are 8 to 10 individuals around our region who are undergoing evaluation. So that's another potential way that someone with suspected or confirmed Ebola could come into our system. I think the medevac issue that got a lot of attention a few weeks ago is really very unlikely, quite frankly. I also think with the active monitoring that public health is doing, we're hoping to move that random individual showing up in one of the EDs or clinics to a more controlled environment, so that should one of these individuals undergoing monitoring within our community develop symptoms, we would know about them, prepare for them, and be able to easily facilitate them into coming into our system in a controlled manner as opposed to the random individual showing up. And this really is a great example of collaboration from the CDC, Department of Health, Seattle-King County Public Health, and other jurisdictions around our state, as well as Northwest Healthcare Response Network, which is really our disaster response team. So from a CDC standpoint, I just want to kind of walk from the national perspective down to our regional response. So nationally, as you've seen in the media, the CDC is now doing post-arrival active monitoring of all travelers from one of these 3 countries, regardless of symptoms. So even asymptomatic individuals who may have been from one of these countries in the last 21 days will undergo active monitoring. They also have been putting out almost daily new guidance because this is a rapidly evolving scenario. And particularly, they've emphasized really how can we protect our healthcare workers, emphasizing rigorous hands-on training with personal protective equipment, no skin exposure, and really I think one of the critical pieces here is dedicated personnel focused on observing the putting on and taking off of personal protective equipment, because the greatest risk for our healthcare workers is really in the removal of the personal protective equipment and potential risk of self-contamination. They've also developed rapid Ebola preparedness teams. These are teams that are actually going on site to evaluate hospitals and systems to determine are they ready to care for a patient with suspected Ebola, and are there potential opportunities or gaps in their preparation. Those teams right now are focused in those areas of the country that receive a greater number of individuals from West Africa. Keep in mind, when you look at travel patterns, we have less than 1% of all those individuals from West Africa who are coming into the U.S. And so those teams will not be here in the Northwest for quite some time. In place of that, what we are doing in collaboration with the Washington State Department of Health and Public and Seattle-King County is developing some regional teams of experts that can then evaluate facilities within our area for their readiness. You've also seen that the CDC and the military have also developed response teams so that should there be another case within our state or our country, that they would be sending personnel. If you look at the military group, it includes critical care nurses, physicians, and epidemiologists, as well as we're seeing now they're increasing the national stockpile for PPE, just like what happened in 2009 with the pandemic influenza issue. And so, again, one of the challenges for all of us has been getting some of the adequate PPE because of back orders, and so this national stockpile will be of great assistance. When you look at our regional approach, again, I think this is really a great collaboration with public health. As Jeff mentioned, all hospitals and clinics have to be prepared to potentially initially identify and initially manage someone who presents with possible Ebola. But we also realize that not all facilities are going to be equipped to provide ongoing care. And so with the collaboration of the Department of Health, we have been actively identifying hospitals and systems within our region who will be designated as potentially prepared to care for such patients. And right now we have identified 8 potential facilities within our system. So it's not going to be just UW Medicine, but we really need, from a regional perspective, multiple facilities who could potentially care for these patients. Again, right now, hopefully, if we do see a suspected case, it would be a one-off individual. But if we had a number of individuals within our community, we really have to do this as a region. Because as we've seen from the Emory experience, even 1 or 2 of these patients could really overwhelm an individual hospital. And so we can't just rely on one medical system. We're still working out issues. For instance, are there differences in a low-risk individual who simply needs to rule out, and can they be managed where they land, versus someone with high suspicion, critically ill, who really probably does need to be transferred to one of these designated facilities. There's also been some discussion around development of a state core team of experts. Again, that could potentially be mobilized. Again, I think this will really vary depending on how many patients we actually saw within our region. And we really appreciate the ripple impact on facility function. For instance, at Harborview, one of our concerns is while we're preparing, we also have to maintain our ability to function as a level 1 trauma and burn center. And so each facility has those balances of their priority populations, their priority missions, while also trying to collaborate from a public health standpoint. Now, my last slide here, looking at our UW Medicine approach, all of our facilities really over the last several months, in particular our 4 hospitals, but also our clinics, our neighborhood clinics, Airlift Northwest, et cetera, have all been actively preparing for this potential. But what we realize is that there's strength if we come together and decrease some of the redundancy in terms of our preparation. And so we have, under the leadership of Joni Spiso as our Chief Health System Officer, as well as Dean Ramsey, basically developed an incident command structure for UW Medicine, led by Ann Newcomb, who already serves as the disaster liaison across UW Medicine, as well as myself, to really develop a system approach to this while we continue to work at each individual hospital. We now have an Ebola steering committee with representation from all the entities within UW Medicine, and we've developed a number of working groups, as outlined here, focused on specific areas to really allow us to come together. An example of how this works effectively is if you look at our supply chain management. So we have had basically every other day calls with our supply chain team, and we're purchasing and getting supplies as a system, which gives us greater leverage power. It also gives us the ability that should we have a case within our system, the ability to shift those resources where they're needed. And so again, that's the real benefit of functioning as a system. We're also obviously working with all of our ambulatory clinics, including the neighborhood clinics, the clinical care providers across our system, developing not only order sets, but really what is our approach to patients who may be critically ill and require dialysis or intubation? What is going to be our approach across the system? Standardizing our education and training, facilities and engineering, our waste management, which is really a critical piece of this process, media and communication, not only how we communicate internally, but also how we externally communicate, particularly with public health, and provide both transparency but also reassurance to the public, and then working with HR and our policies. So that just gives you a broad overview of where we're at from a system. And then, John, you can discuss specifics here at Harborview.
Thank you, Tim and Jeff, and good morning, everyone. Thank you for inviting me. I have just a few slides, and I want to leave some time for questions, so I'm going to go through these pretty quickly. I'm here representing sort of the effort at Harborview Medical Center in the context of what Jeff and Tim and obviously Shevin have talked about. And I'm also representing that long list of people at Harborview, the critical care teams, nurses, the docs, the environmental services folks, laboratory medicine, supply chain. The list is really endless and involved many, many, many people at Harborview in the effort to get this up and running. It's required a huge amount of activity over the last about 6 to 8 weeks. spread across. And I'd like to acknowledge just a couple of people. Vanessa McCarowitz is our clinical operations person out of infection control, who's really led the efforts in training. Deb Metter and Kat Ward, Kat's from the ER, who've done a lot of the groundwork in getting this rolling and making everyone feel safer. So I'm really focused on Harborview. So one of the things, Jeff sort of alluded to this, but I just wanted to, again, reinforce that we've now developed at least countrywide experience to some extent and learned from each other. We've gotten information from how Emory has taken care of patients and how they protected healthcare workers, how Nebraska's done it, how Bethesda's, the NIH Clinical Center has done this. Hopefully we'll learn more from Bellevue, which is a non-biocontainment facility, but they appear to have done things quite well, and we'll learn about that in the future. And we've also learned from some of the missteps and mistakes in the Dallas case, again, at a community hospital. But as of now, everyone has been discharged, and aside from those 2 nurses in Dallas, everyone has survived, excuse me, and Mr. Duncan in Dallas. There's been no transmissions to healthcare workers, everyone's been discharged in good shape. So again, the clinical experience, and how do we roll in that clinical experience in the United States, as well as our colleagues in West Africa, into taking care of patients here and protecting healthcare workers. So as you can see, all those greens are all discharges, including the folks who aren't healthcare workers, those journalists and so forth, have all been discharged. So one of the things I'd also like to acknowledge, and Jeff alluded to this too, is that there's been an evolution in how we are going to take care of folks. The original recommendations were a tiered approach to folks who were sort of low risk, someone who was asymptomatic, who had risks for Ebola virus infection, with recommendations for sort of the personal protective equipment, or PPE, you see on your left-hand side there. And this is, I think, is what was kind of used in the Dallas situation. Harborview decided to go with the higher level of protection, started to use first a negative pressure room for anyone with suspected or known Ebola virus disease. That allows, initially the plan was to put people with low risk into a normal room, isolated, people who were very sick or required procedures involving the airway to go to negative pressure. But in an effort to minimize movement of patients around, we decided to stay at a negative pressure, and then to use personal protective equipment similar to this, maybe not with this whole shroud where we're covering all equipment, covering all skin, but using N95s, face masks, an impermeable gown, and booties. But as you can see, I think everyone's been aware through their publications to the CDC and the experience in the United States, what folks have really moved to is really much more complete coverage of all body surface area. But actually, just as importantly, is the fact that this is very hard to work in for long periods of time. You heard Dr. Jacobs' description of being very hot in West Africa. But anybody who's worn an N95 mask, as you can see in the center there, for more than 15, 20, or 30 minutes, you realize it's very hard to do any work. And we learned from the Emory experience, the nurses are often in the room for 3 hours at a time. And so wearing that for that long could really get in the way of taking care of a patient. And we know as soon as your face gets itchy or something like that, it's just human nature to reach up and start bumping things. And that's the things that lead to contamination. And so what we really move towards are these PAPR units. This is a shrouded PAPR, so you get complete coverage in suits that cover all exposed skin. This PAPR is not, again, for filtration. As Jeff mentioned, this isn't an airborne disease, but it provides a comfortable working environment so that when the nurse, really the person who's doing most of the work, or the clinicians are in the room, they can be comfortable, focus on the patient care, and not be distracted with discomfort, as really Shevin was talking about. So let's talk a little bit about what's going on at Harborview more specifically. And again, I want to go through every detail. This is Dr. Jamie Shander, one of our emergency room physicians. And this is our first drill. We have designated rooms in our emergency room, a negative pressure room there, another negative pressure room in our neuro ICU, which would be used. Jamie had undergone prior training in the appropriate PPE, and then just-in-time training just prior to this drill. It does require a fair amount of training. At Harborview, we have a 4-hour training program for the initial one, and then repeated trainings after that, and how this was all put on and how it's all removed. One of the key things, is Tim mentioned, is this idea of team approach. So no one be in a room who hasn't been trained, no one be in a room who is alone. Basically, in a paired system or a buddy system, there's going to be someone at the bedside, and there's going to be someone who's watching the healthcare provider at all times. And we wouldn't vary from that at any time. So Jamie would be in there with a nurse, or the nurse would be in there with Jamie or another nurse as they go through it. We've designed, this is the layout of the room in the emergency room. So we have a cold anteroom where the gear can be put on. We have a corridor where things can be stored. We have a hot room where a patient is actually taken care of. And then we've, in the room itself, have a warm room number 1 where some of your equipment gets decontaminated. And then we have a warm room number 2, which is actually in the ambulance bay. And then across that bay, the ambulance entrance, across that way is the shower area. So healthcare workers can, after they go through decontamination and doffing, they can go and shower down and change their clothes. Now, the question is, like, how do you build this? Here's an example. Here's Rusty from our engineering group. He's an amazing guy, and that whole team's really been amazing. Basically within 45 minutes of a patient hitting triage, they can build this biocontainment doffing area, which is really this brown site here in that breezeway where the ambulance patients come through, so that it'd be a safe place to store gear and remove all gear while you're in the hospital. While that's going on, we're setting up the upstairs room. So this is one of our ICU rooms. You can see in your top left corner is the negative pressure ICU room for patient care. This is actually a corridor, which would be closed off. I'll show you pictures of that in a second. Again, the same process where there'd be a cold donning area for putting on your PPE, the hot zone here, and then exit here. It's actually through a hopper room. The hopper obviously would not be used, probably in this situation, into another room that's not negative pressure for warm room 1, 2 for doffing, back out into the hallway into the shower area and changing. And so while that patient is potentially in the emergency room or when we get a call, we can prepare this site. So this is, for those of you who've been to the neuro ICU at Harborview, this is that first corridor to the right. You know it's a long corridor, and you can see it's blocked off here by this sheet. Trying to make this work here. This is a plastic sheet here that basically closes off that corridor. And every place you see a piece of blue tape, engineering would put up another one of these sheets. This is in the first room, which would be the warm room for removal. And again, every place you see this blue line, there'd be another sheet put up. So basically within 2 hours of someone coming to the emergency room, we could have basically a biocontainment facility built at Harborview ready to take care of a patient safely. We wouldn't need to have this completely constructed by the time the patient gets into the room, but it could be built around that patient's transfer. I would like to mention, we would try to minimize movement and placement of a patient. So if we knew someone was coming in from the community, we would try to bypass the emergency room, go straight up into the ICU, and have the evaluation taken care of up there. We've also put in intercoms here so that folks can communicate with the patient. There's an intercom at the head of the bed and one built on the wall so that interpreters will be available and you can have just conversations with folks without actually having to go into the room and also be able to communicate with the team. We have checklists for entering and exiting. One of the points is that when you come out of the room, we're not going to expect even a trained person to know what's the first step in removal of their equipment or what's the 4th or 5th or 10th step. There'd be someone there, a site supervisor or site commander, that responsibility would be to tell the healthcare worker how to remove their equipment in a very specific way. And that way the healthcare worker, as they come out of that environment, don't have to think about making any problems or making a mistake. And it's all checklisted, so even the site commander doesn't have to memorize it. And this is very similar to lots of things we do in healthcare. We're doing training sessions. This is some of the pictures. There's Deb Metter in the back, who's one of our clinical nurse specialists, who's been doing a lot of the training. This is that N95 version with the face mask and these impermeable surgical gowns. And here's one of our respiratory therapists, one of our anesthesiologists who are engaged in the first training in sort of the ideal state, of PPE with impermeable gowns, impermeable boots, double gloves, the PAPR with the shrouds. And honestly, when we've done these in drills, people feel quite comfortable working for a couple hours in this gear. It's cool, comfortable. We're obviously not in a 90-degree Fahrenheit situation like Shevin has been. And so, again, people will be able to focus on the work at hand without being distracted. And also prevents those inadvertent bumps and scratch, moving your bangs and so forth that can happen with the other gear. So key actions, one of the things we did, we really focused on the development of safe and effective protocols. We probably delayed our communication efforts a little bit, but we really needed to get online in case someone showed up in our emergency room, our clinic, or someplace else. And then we really focused on communication and education. And this, as Jeff alluded to, really corrects misinformation, even among our staff. Training has been really, really important, and it normalizes the work. When it was really interesting, when we did our first drill, when we moved that patient from the emergency room into the ICU and that door closed, everyone was like, you could feel everyone's breath, everyone just calmed down. And as one of the nurses said, it felt like they were home. We're like, okay, the patient's in the ICU. We know how to do this, right? The door's closed. We're comfortable. The gear, it gets normalized with more training you do. And everyone's like, you can just feel everyone, we got this. And the more we do it, the more it normalizes things. It demystifies the disease, which I think is really important, certainly with discussion later time, and demystifies the whole process. We have to be ready to modify. As I mentioned, this has been evolving, and we have to learn from our colleagues in West Africa, who are really the experts, Shevin and his team and others. We have to learn from our colleagues here in North America and other places. And I think, as Jeff pointed out, we don't see an end in sight, so we have to prepare for the long haul. This isn't something we're going to just ramp up and do a ton of work now and then let it die. This is something we're going to have to prepare this team for a long period of time, months, maybe longer. And honestly, when we think about the last 10 years, West Nile, SARS, MERS, H1N1, and now Ebola, these diseases continue to emerge, and we have to be prepared for any and all as they come forward. And then finally, and hopefully, obviously, an important part of this is that, as Jeff mentioned, the focus really needs to remain on West Africa. This is not a problem for us. It's important for us to be prepared, but as Jeff mentioned, an outbreak here is more than unlikely. And we need to continue focusing our community efforts and communications and education on the population that's really being devastated by this in these 3 countries. And that's where I will end, and I'm happy to take questions with the rest of my colleagues here up at the front, I guess. Is that right, Rachel?
So I really want to extend a big thank you to Drs. Duchin, Lynch, and Dellit for coming today. So we're going to now open it up for discussion to our panelists. Yes.
Really interesting. Could you talk a little bit about the strategies for containment in Africa?
Well, remotely, from the third-hand perspective, the issues in Africa have been, the outbreak was unanticipated and missed for a long time, for months before it was recognized. And there was I guess people have characterized it as a failure of imagination, that no one really thought ahead to predict what might happen if Ebola, which was a disease that had previously been confined to jungle villages with very small numbers of persons and could easily be snuffed out, got into urban locations, which is where it's transmitting now, and that's why it's such a problem, and crossing borders, highly populated areas. So the basic containment strategy for Ebola, regardless of the setting, is rapid identification of cases, isolation of cases so that when they become most infectious later in the course of illness, they're not transmitting to others in their household and community environments, and identification and monitoring of contacts of persons who've been exposed. And it's proven to be very difficult in the urban setting currently because there's very small number of public health workers, the public health infrastructure is poorly developed, and these people tend to have a lot of contacts. They initially resisted, well, there's denial of the fact that this was Ebola. There is suspicion that it was intentionally seeded, that it was another disease, that it was something that others had introduced in order to experiment on the population, and so there was a lack of cooperation with all aspects of disease control efforts. That's changing now. People are becoming more or better educated about what's actually going on, how the disease is transmitted, and how to stop it. But the basic containment efforts, which involve contact tracing, case identification, contact identification, and so on, are unchanged. There's progress being made, but not nearly enough. The outbreak transmission has been characterized as recently as this week as intense in all 3 countries, and the number of cases are increasing in Sierra Leone, and there may be something about to erupt in Mali. A few days we'll know, within a week or 2. Does that sort of get at what you were asking about? Okay. Good.
Yes, go ahead.
Yeah, I'm wondering what the projections are for the numbers of cases likely to be in the region, realizing how difficult those estimates might be. And related to that, do we know what the military facilities in the region, what their plans are either for participation in control, and also whether Madigan and other regional medical centers are likely to be involved with care of patients with Ebola?
Okay. So starting with the second question, the military are dealing with their own. They're not going to be involved in the civilian response to Ebola cases. Madigan is currently monitoring quarantined servicemen, and the military has informed us on multiple occasions when we've come to them about this and other issues that their mission is to their servicemen and not to the civilian population. They do have people on base that they see some responsibility for, but off base, no. As far as numbers of predicted cases here, I would say small. We have right now 10 people or so, that we're monitoring who returned from areas where Ebola is being transmitted, or some of them may be healthcare workers, others just travelers. As Tim said, we get less than 1% of the total number of travelers that come to the U.S. from those areas. So I think the risk is low, but I wouldn't be surprised if we had a case or two. If this disease becomes endemic, if we don't get the disease under control in West Africa, if it gets into a country like China or India, it'll never get pushed back into its box, into its reservoir, which are probably fruit bats. If it becomes endemic in the human population, this is going to be an ongoing, horrible, ever-present threat globally. So we're really hoping that people put all their energy into getting this thing controlled in West Africa. But the risk here currently is low.
Thank you for a wonderful presentation. Jeff, have you been working with the schools, the public schools, and the daycares, for example, when you showed the slide about the fear-mongering? We don't want that to happen in our community. Somebody cares for a patient with Ebola, and all of a sudden their children can't go to school or can't go to daycare.
Yeah, well, it's happening here, although not maybe, to as great a degree because we haven't had a real case. But there was a letter that was sent to people who go to a large national, or not who go to, but whose children attend a large national daycare chain in several outlets here in King County that said if you or your family member have been in an area where Ebola is being transmitted, you cannot come to daycare. Your children can't come to daycare. And this was brought to my attention because one of our regional hospitals was trying to identify an Ebola team, and one of their healthcare workers who wanted to be on the Ebola team showed this letter that said, if I'm on your Ebola team, if I have an exposure to an Ebola patient, my kid can't go to daycare. This is a problem for us. So this is a national chain, so we sort of pushed that up to the feds to try and address. But these types of issues are, this education piece is huge. And currently, we're trying to push the same information out to the public, regardless of whether they're school, daycare, whatever. We're not targeting schools particularly now because we don't have cases. But that is something that we invariably would have to do. I mean, with H1N1, it was an issue. With SARS, it was an issue. I'm sure it will be an issue if we have an Ebola case. But there is this real misunderstanding that contacts or people that have been to Nigeria 3 months ago, or someone who was on a plane with someone who later was found to be a relative of someone who traveled to Nigeria, presents some sort of risk of transmission. And that's the outrage thing I was talking about. The risk equals hazard plus outrage. Until the public become a little more comfortable with this disease, it's very hard to change that behavior through rational sort of scientific data. It's really an emotional reaction that really has to calm down over time, I think.
I just want to follow up on that a little bit in that, the response to the epidemic right now is insufficient. We can't rely upon a small group of volunteers to get this under control. And so what the future answer is unclear to me, but it's a lot more people are needed. And if we're going to include people from North America and Europe in that response, there has to be an effective way to take care of them when they come back. We know in our own area, a healthcare worker who returned from West Africa who worked for Medical Teams International had a terrible time when he returned, even though he had no symptoms, no signs, anything like that, where his kids were disinvited from a birthday party. He was asked not to come to his house of worship. And this is for a perfectly healthy person who's simply doing what needs to get done in West Africa, back here at home. And so we got to figure out an answer to both of those questions. The details like Jeff is talking about and you're mentioning, but also how to deal with this response and in a way that's sustainable for our folks coming back here.
What are the lab tests that either confirm or rule out people, and how soon are they reliable? Are we talking serum or people?
Yeah, it's a blood test for PCR. The good thing is that the state lab in Shoreline is one of 13 labs around the country that is approved to run this test. And so we have, again, very good partnership with the Department of Health so that we have a specimen day, night, weekend, and they'll bring in their techs to run the test. So hopefully, again, they technically say 1 to 2 days, but in reality, they can turn that around in 6 to 8 hours. The challenge is, as Jeff alluded to earlier, when someone first presents with symptoms, 50% of the time they may be negative on that first test. And so if there's high suspicion, you may have to wait 3 days and retest them. But it is a test that at least is done here locally, and so we have the resources to do that.
We have time for another question if anybody has one.
Could you talk briefly about the ethical considerations that go into decisions around procedures with patients who are either suspected to have Ebola or confirmed to have Ebola? I'm talking mostly about things like intubation, CPR, delivery.
And I think that's a very good point. I think that as part of our deliberation, we have bioethicists involved in those discussions, both Denise Dzunsky, who's the interim chair of the bioethics department here at the university, as well as Mark Tonelli, for instance, one of our pulmonologists here at the U. And I think those are challenging questions. In many respects, what these patients die from is essentially volume loss and electrolyte disturbations, and so we have to look at that issue in terms of particularly coding. I think is the bigger issue. Dialysis, again, I think you don't want to do anything that's going to put our healthcare workers at risk, but at the same time, if you look at the people who have recovered in this country, a couple of them have undergone successful dialysis, and so I don't think that we can say black and white that we would not do that. In fact, we've had very good discussions with our nephrologists and Northwest Kidney Center who are very willing to partake in those discussions. I think codes are a challenge, and I think foremost, even if we're taking care of someone with tuberculosis and they code, you want to make sure that you first protect the healthcare worker. Make sure they have, in that case with TB, the appropriate respirator on before they go into that room. Same thing here. We want to do things in a manner that, number one, protects our healthcare workers. And then I think there has to be that individual judgment in terms of what is or is not being done. I think these are ongoing discussions, and this is one of the reasons why we're trying to come at this from a system approach so that we have a uniform kind of standard across UW Medicine in terms of how we're going to address some of these difficult issues. I think number one is making sure we have all the key individuals at the table to have those conversations, but they're not easy discussions.
You know, I've kind of undergone an evolution in thinking about this a bit over the past 3 months. You know, when you first get involved with this, you hear about these mortality rates of 50 to 75 or 90%. But that happens when you have nothing. That's what happens when you get Ebola and you have a street or you have a hut and no care. And we're learning in North America that, again, this experience with all the patients here, aside from the unfortunate case of Mr. Duncan, who presented quite late or later in his disease, that everyone has survived. As I tell everyone, we have people who have much higher mortality in all of our hospitals right now, right, compared to people with Ebola. And we do have to think about this is a treatable disease, and we need to work on demystifying it. To me, if we can protect healthcare workers, there's no reason not to do the things that need to get done to save their lives. That's my personal.
I want to say thank you to all our panelists.